Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What is new with peptic ulcer disease and heartburn? Find out more right now. My guest this evening is Dr. Aaron Fond, a noted gastroenterologist practicing with the MedStar Medical Group right here in Montgomery County. Aaron, welcome to Housecall.
Thank you for having me.
So briefly tell our viewers about your professional background.
Sure. Well, so I'm originally from New Jersey, but did my college in Texas at Rice University, and then came all the way back to the East Coast to do my medical school and graduate school, where I got a PhD at the University of Virginia in Charlottesville.
What's your PhD in?
It's in immunology.
How interesting, yeah.
Technically it's in microbiology, but I studied immunology.
Sure.
So. And then after that, I went back to Texas in Dallas, where I got I did my residency and fellowship in gastroenterology at UT Southwestern in Dallas.
Very nice.
Yeah.
So the topic at hand is several practical common disorders. One, of course, is reflux esophagitis. The other one is peptic ulcer disease. Let's start off with peptic ulcer disease. Tell our viewers what are typically some of the symptoms of an ulcer.
Sure. So the kind of most common symptom of peptic ulcer disease would be pain in the middle of the stomach. One of the classic kind of textbook symptoms of peptic ulcer disease is that it improves with eating. But some of the kind of warning signs of peptic ulcer disease would be, vomiting blood, certainly, or having blood in the stool, like black tarry stools. But the most typical symptom is that center abdominal pain that can be quite gnawing or stabbing pain.
And how is it diagnosed, this condition?
Well, sometimes we can see it on a CT scan if there's an ulcer eating away into the wall of the stomach or the small intestine, but really the way we confirm that diagnosis is with something called an EGD, which is an endoscopy test where we look with a camera into the esophagus, stomach, and the first part of the small intestine and see those ulcers visually with our own eyes.
And the patient is asleep for this procedure?
Yes. Yeah. Otherwise it would be quite unpleasant. But yes, a patient is asleep for the procedure and shouldn't be painful for the patient at all. Yeah.
And how long does such a procedure take?
An endoscopy is actually quite quick. So it only takes about 10 to 15 minutes. And during that time, we can look in those areas that I mentioned and take biopsies if we need to. And if there's any bleeding, we can even stop the bleeding while we're there. So it's not only a diagnostic test, but it can be a therapeutic test as well.
And for a test like this, it should be covered by insurance?
It should be, yes.
So once you determine that somebody has an ulcer, what are some of the causes of a peptic ulcer?
Yeah, well, so there are two very common causes of peptic ulcer disease. The first would be certain medications that we classify as NSAIDs, NSAID medications. And those are things like ibuprofen, Motrin, naproxen, those kinds of pain medications kind of in that category. And that can cause damage to the lining of the stomach or small intestine and lead to ulcers. The second major cause of peptic ulcer disease is an infection with something called Helicobacter pylori. And as a UVA alum, I am obligated to mention that Barry Marshall taught at UVA and won the Nobel Prize for the discovery of H. pylori. Mm-hmm. But that infection is, in fact, one of the most common infections worldwide. Sometimes it doesn't cause peptic ulcer disease, but it is one of the most common causes of peptic ulcer disease.
So if somebody has a peptic ulcer, for from Helicobacter pylori, is that treated the same way as somebody who has a peptic ulcer from an anti-inflammatory drug like Motrin or Aleve?
Yeah, not exactly. So with peptic ulcer disease that's due to those anti-inflammatory drugs, often we can stop that medication and start something to suppress the acid in the stomach, and that can heal on its own. With Helicobacter pylori or H. pylori, we treat it with antibiotics to eradicate the infection, and that usually resolves any residual inflammation.
Okay. And how long is that treatment provided?
Well, the treatment takes about 2 weeks or so. Depending on the treatment, it can be a few pills multiple times a day, so it can be a little burdensome in that way, but it is important to get rid of the infection. But it only takes about 2 weeks to eradicate.
So why is it important to treat H. pylori?
Well, other than preventing peptic ulcer disease or treating peptic ulcer disease, this infection can actually also lead to gastric cancer. And so having that infection there for years and years and years can lead to gastric cancer. So it is important to treat it to prevent that as well.
And in terms of NSAID, drug-induced ulcers, how long do you treat them?
Well,
once you stop the drug.
Yeah, usually we do 2 months of treatment with the acid-suppressing medicine. Depending on what is seen on endoscopy, a lot of times we'll go back and take another look to make sure that it's treated, but generally about 2 months.
Let's go on to the different categories of medicine available to treat acid peptic disorders, whether it's ulcers or even reflux esophagitis, our next topic. What are some of the categories of drugs available?
Sure. So with peptic ulcer disease, we tend to use, well, now really two classes of medications. The first would be the proton pump inhibitors, which suppress the stomach's ability to make acid and really raise the pH or lower the acidity in the stomach. Mm-hmm. The other group that's newer is the main drug on the market is vonoprazan or Voquenza, which does something similar but in a different way, a different mechanism. Those are the two that are used to treat peptic ulcer disease. Now, you mentioned reflux or like acid reflux and heartburn. We also use other medications for that aren't really used for peptic ulcer disease, things like histamine receptor antagonists. So if you've heard of Pepcid or famotidine, that's used for that. And then we can also use topical, I guess, kind of cooling medications like sucralfate or Gaviscon, things like that.
Sure, sure. So when should somebody, if they're having this discomfort that you've described, at what point should they seek medical attention? If it's just an occasional discomfort, or is it more of a repetitive issue?
Yeah. So for the pain that's associated with peptic ulcer disease, I think if it's happening frequently, it could either be something like peptic ulcer disease or something less concerning like like dyspepsia. And both of those things, I think it's worth talking to a doctor about rather than trying to differentiate those on your own. Mm-hmm. Now for heartburn, that's a little bit different because heartburn is so common. I think for heartburn, if you're having symptoms after trying some of the over-the-counter medications, at that point it's time to see a gastroenterologist.
Sure. Circling back to stomach ulcers.
Sure.
Are all stomach ulcers benign or ever cancerous?
That's a great question. So unfortunately, stomach ulcers can be a sign of gastric cancer. And so sometimes if we see on the endoscopy, we see an ulcer in the stomach, after treatment, we'll go back and make sure it's gone. And part of the reason for doing that is to make sure that it wasn't cancer. Mm-hmm. if biopsies were taken and it wasn't cancer, then that's also reassuring. But a lot of times we want that confirmation that it's completely gone.
Aaron, explain to our viewers what exactly is the difference then between peptic ulcer disease and heartburn?
Sure. So with peptic ulcer disease, the actual lining of the stomach or the small intestine gets eaten away and it creates an actual ulcer, which is like a sore. With heartburn, the acid is washing up into the esophagus and can cause irritation or inflammation, but really that typical heartburn, chest pressure or burning sensation.
Mm-hmm. So what test can be utilized to evaluate reflux esophagitis, heartburn?
Sure. So an endoscopy can be done to look for acid reflux. With an endoscopy, sometimes we'll see inflammation in the esophagus. Otherwise, there are other tests to actually measure the acid coming up into the esophagus, but that's a little separate.
And what do you do when you do an endoscopy? What are you looking for?
We're looking for evidence of inflammation in the esophagus. So normally the esophagus has a very smooth, uniform texture. With reflux esophagitis, which is inflammation of the esophagus, we'll see these linear erosions, and it looks like it's been worn away by acid.
Okay. We're going to pause briefly for a public service announcement. More with my guest, Dr. Aaron Fond, and we'll be discussing a variety of GI disorders: peptic ulcer disease, reflux esophagitis, and Barrett's esophagus. We'll be right back.
Every day, thousands of kids start vaping. And I can't let this happen to my kid. Of course, it's awkward to talk to your kids about the dangers of vaping. Hey, bestie, how's sketches, baby? It's hard to get their attention. Ready? Go. Yes, look at that. You didn't turn yours over. So if you want to talk to your kids about the dangers of vaping, you have to get it trending. Right, Backpack Kid?
Let's do it.
First, invite your kid to do the vape talk. Let's try this. All right.
Why is he here?
Yeah, I gotta get it trending,
No.
honey.
Come on.
To the left. To the right. Let's go.
Oh, honey, can we talk?
Yeah, what's up?
I see a lot of your friends vaping.
Visit talkaboutvaping.org for tips on when and how to have the vape talk.
We're back. My guest this evening is Dr. Aaron Fond, and we're discussing ulcers, reflux esophagitis, heartburn, and another condition called Barrett's esophagus. Aaron, when we paused for the break, we were discussing heartburn, reflux esophagitis. And that raises an interesting question I'm sure many of our viewers are thinking about. And that is, does stress cause ulcers or heartburn? Because for so many years, decades, people would say, don't be so nervous, it'll give you heartburn or an ulcer. Is there any truth to that?
Not really. In reality, stress doesn't cause ulcers in the way that we used to think of it. Certainly, a lot of stress can aggravate pre-existing GI conditions, but it's not in the damaging way that we normally associate with it.
Sure. So you mentioned some of the ways to evaluate people with reflux esophagitis. Once you've done your evaluation, what are some of the treatment options for that condition?
Yeah, that's a great question, because we are very fortunate to have many treatment options. So people might try things at home like Tums or Rolaids. Then there are other over-the-counter medications that like I mentioned before, like Pepcid, Famotidine. And then we have things like Nexium or Prilosec that are taken every day to prevent the symptoms. And then there are other medications that we can use that actually prevent the contents of the stomach from going up, like alginate, which is Gaviscon, if you, for those of your viewers who have tried that. And then finally, I mentioned the vonoprazan, which is a newer medication to reduce acid in the stomach, and that can also be used for reflux esophagitis.
Sure. How important is dietary management when it comes to reflux esophagitis?
It can be very important or not. So it depends on the person. So there are a lot of anti-reflux diets. For some people, they notice really specific triggers with heartburn, things like coffee, chocolate, citrus, like orange juice, things like that. But if people don't have those triggers, I tend to advise people not to avoid them. But if they do, it can be very, very helpful.
How important is weight reduction in patients with reflux esophagitis?
It can be very helpful. Now that obviously can be very difficult. Everyone who's tried to lose weight knows how difficult it can be. But weight reduction can make a big difference. So anything that puts pressure on the stomach can force acid upwards. It's always this battle between the lower esophageal sphincter, which is at the bottom of the esophagus and prevents acid from getting up into the esophagus, and the pressure within the stomach. And so anything that would overpower that lower esophageal sphincter and push acid upwards can make heartburn worse. So, weight reduction, trying to have gravity on your side, so not laying down flat or upside down. And then if you are laying flat, making sure that your stomach is empty at the time you do that so that there's not as much pressure in the stomach. But all those things can make a difference and make heartburn symptoms worse.
Do you have people sleep propped up?
I do. I usually recommend, in terms of lifestyle modifications, I usually recommend that people sleep at a slight incline. What I don't want people to do is sit upright, like in a chair, or prop themselves up with pillows to the point where there's a bend in their waist, because again, that will put pressure on the abdomen and can make heartburn worse. But if you're sleeping flat at a slight incline, that puts gravity on your side to try to keep acid out of the esophagus.
Now, if patients have been prescribed all these reasonable first-line therapies, dietary management, weight reduction, and any of the pharmacologic agents you've mentioned, and if they're simply not responding, what other therapeutic interventions are available to treat medically refractory heartburn?
Well, that is a fantastic question and can be very difficult to treat. So a lot of times we first try make sure that we have the diagnosis correct. And so that's when we'll do, I mentioned another test to look at the acid going up into the esophagus, and that's called pH impedance, where we look at the actual acidity in the esophagus. And we do that to make sure that what we diagnosed as acid reflux or heartburn is actually that. But medically refractory heartburn can be very difficult to treat. There are surgeries to prevent acid from going up into the esophagus. They tend to be more effective in those that responded to medical therapy. And so when people are medically refractory to therapy, it can be very difficult, yeah.
Okay. Now, what are some of the potential complications of reflux esophagitis if it continues unabated?
Well, so acid reflux can cause inflammation in the esophagus, and that's, as you mentioned, is reflux esophagitis. Reflux esophagitis can cause severe ulcers, just like peptic ulcer disease, in a slightly different way. And so people can have enough inflammation that it causes bleeding in the esophagus. It can cause difficulty swallowing just from the swelling from the inflammation. It can impact how the esophagus is moving normally to swallow. And then ultimately, the esophagus lining can respond to that constant bath of acid by changing the type of cell that lines the esophagus. And that is considered a precancerous change and ultimately leading to esophageal adenocarcinoma.
And what is that condition called?
Right, so that change in the lining of the esophagus is called Barrett's esophagus. And it's not cancer, but we recognize it as a precancerous condition, and it greatly increases the risk of developing esophageal cancer.
Are there any particular groups of patients that are at risk for developing Barrett's esophagus?
Yeah, so the risk factors for Barrett's esophagus, generally we say men are at higher risk than women. Having acid reflux for greater than 10 years puts you at risk for Barrett's esophagus. White men are at a greater risk than other ethnic groups. And then obesity increases the risk of Barrett's esophagus.
So how do you evaluate somebody for Barrett's and make sure it's not just garden variety heartburn?
Well, that's when endoscopy comes in.
Sure.
And so not everyone with heartburn needs an endoscopy, but if you are at a higher risk for Barrett's esophagus, or if you're medically refractory to therapy, then we recommend an endoscopy to take a look. And so with endoscopy, we look at the bottom of these, well, we look at the entire esophagus, and we're looking for that change that is typical of Barrett's esophagus. And you can see that the esophagus is normally kind of a pale white color and very smooth. And once it changes to Barrett's esophagus, we describe it as salmon-colored mucosa. It's pink and a darker color. It looks more like the stomach.
And are all patients with Barrett's the same, or is there a spectrum of severity?
Yeah, you know, there certainly is a spectrum. The esophagus tends to be about 35 centimeters long or so, and if you have severe reflux all the way up to the top of the esophagus, you can get Barrett's pretty high up there, and that puts you at a greater risk for esophageal cancer than if you have, let's say, 2 centimeters of Barrett's esophagus. We tend to divide people between short segment Barrett's esophagus and long segment, and that cutoff is 3 centimeters. But conceptually, you can understand that someone with 20 centimeters of Barrett's is at a higher risk than someone with 3 centimeters, let's say. Additionally, there are stages within Barrett's on the pathway to cancer. And so we take biopsies of the Barrett's esophagus mucosa, and the pathologist is looking for those steps along the path where it's not quite cancer yet, but it's further along than someone without those changes.
Let's then transition to treatment options. Briefly tell our viewers what are the medical treatment options when somebody has just Barrett's, no precancerous changes.
Sure. So with Barrett's, without those further additional changes on the pathway towards cancer, we really use the proton pump inhibitors. The other medications are not as well studied for Barrett's esophagus specifically. And so when I say proton pump inhibitors, I'm talking about Prilosec, Nexium, so that's omeprazole and esomeprazole, as well as other medications within that class.
Now we'll talk about Barrett's when they have precancerous changes. What are the treatment options then?
So medically, we still offer the same treatment options, but additionally, we want to take steps to resolve the Barrett's, to prevent it from further going towards cancer. And so there are procedurally things we can do to prevent that progression. You can, in some ways, burn the mucosa. I'm trying to think of a better analogy, but we use radio frequency to kind of eliminate that mucosa, and it heals without the Barrett's still present. And that's to get rid of any what we call dysplasia, which is further progression towards cancer.
So if somebody has advanced precancerous changes, what do you recommend at that point?
Well, we recommend those procedural interventions, and that's done by advanced endoscopists. And so I personally don't do those procedures, but I certainly refer people to those that do, because it is important to take care of that and prevent that progression to cancer.
Is there any data to suggest the genetic risk for the progression of reflux to Barrett's and Barrett's to esophageal cancer?
There is, So there are, I guess, inherited predispositions. In terms of the actual genetics, like what genes are involved, I don't have a great answer for you. That's a great question.
Yeah, I believe there's ongoing genetic studies in that
Of course,
regard.
yeah.
So briefly, if our viewers have any questions, how can they reach you?
Well, I think the best way to reach me is to look at my website through MedStar Health. I go to actually multiple clinics in this area, so depending on where you live, calling the clinic closest to you is really the best way.
Thank you for joining us and providing a very informative interview.
Thank you for having me.
My pleasure. My thanks to Dr. Fahn for a superb interview. My thanks to my team here at the studio for putting this program together. And finally, my thanks to you, the viewer, for welcoming us into your home. Our program next time is going to be an important one. If you or any of your family suffer from dizziness, vertigo, you'll want to tune in when I interview Dr. Ezra Cohen, a noted neurologist with the Neurology Center, practicing right here in Montgomery County. See you then next time for another edition of Housecall. Good evening.